Hi, this is Joe Mullings with The Other Side, and today from Boston, I've got Dr. Scott Sigman with me. Dr. Sigman is an orthopedic surgeon and also has a interesting title that I'm going to let him share with you that I'm fascinated by. Would you mind, Doc?
It'd be my pleasure. I usually lead in the same way. So I like to describe myself as Dr. Scott Sigman, the original opioid-sparing orthopedic surgeon, healer of knees and shoulders left and right, social media influencer, hashtag follow the fro, and now host of the Ortho Show podcast.
Follow the fro. I'm digging that. We'll come back to the opioids and the fro
Yeah,
for sure.
awesome.
Yeah. So you're in Boston. What's going on up there right now at this time in this whole crazy COVID situation?
Yeah, so we're pretty much shut down. Basically everybody's at home except for its essential employees. From the standpoint of medicine, I'm in a practice of 11 docs, private practice. We have furloughed about 45 of our employees at this time. We're open bare minimum. I'm seeing now 40 patients a week when I used to see 40 patients a day. 80% of those are telemedicine. That's a good topic that we've been able to move into, and we're doing our best to try and provide acute pain relief and the emergency type visits. We want to unload the hospitals and the emergency rooms to give a venue for orthopedic urgencies. Our hospitals, it's not so bad. I don't want to get ahead of myself here, but we keep talking about a surge every day, and we're not seeing it yet. I would say in my hospital north of Boston, I don't want to use names so I don't get in trouble, but I would say we have about 40 patients that have a diagnosis, a confirmed diagnosis at this point. These are sick people. I don't want to lighten it. They are on ventilators, and even the ones that aren't on ventilators are sick. But we haven't seen this doubling down effect every 3 to 4 days. Now, New York City is bad. I mean, my friend is Bill Levine, is the chairman of orthopedics at Columbia. They've got residents and fellows working in the emergency rooms. It's all hands on deck. The orthopedic attendings are functioning as primary care doctors. In Detroit, another friend of mine, Sharif Bachet, is an orthopedic surgeon. They've completely shut down, overwhelmed with disease and bad disease. But yet, I talk to my friends in Tennessee and in Texas and in Las Vegas, and they don't have any patients.
Yeah, and it was this morning we were on with a urologist who's a roboticist surgeon out of, what was he, Madrid, and he let me know that a number of the caregivers, frontline caregivers in Spain, are sick. They got sick. They weren't protected because of PPE, and now he's a urologist who knows nothing about respiratory medicine, is now on the front line. And so, there are cities that are absolutely getting crushed, and others that, I'm not, I'm happy we were overcautious, and maybe because we were overcautious that it never came. And you always have to worry about that too, that, oh, we overcooked it. No, I think the reason it didn't end up catastrophic is because we maybe overcooked it.
And it's good, and I'm glad that we have done that. I can tell you, people are getting itchy. I'm getting my boys in Vegas are like telling me, we've got plenty of PPE here. And you would think that we should be able to shift PPE around so that we can get everything that they need in New York, New Jersey, or Detroit. But people are starting to wonder when they're going to get out and start being able to do elective surgery. Elective surgery is essentially shut down across our country at this point. Only urgent and emergent type procedures are being done. But it's hard, when they're sitting there, their hospitals are empty. They have a surgery center that's clean. They have materials, and they want to start getting our economy moving again. And, so there's an argument, but yet the people in New York and New Jersey, my friend Sean McMillan is an orthopedic surgeon. They're training him on how to use a vent and be in the ICU. I mean, it's crazy. I mean, he's a knee and shoulder guy. I'm like,
But that's the argument. We were on the other day with a leader in the med tech industry, and we were supporting it. It's like you can't take a monolithic approach to re-engagement across the country, and certainly you have to respect that three asymptomatic people who travel on a plane and then go into a city can kickstart this again. There's no doubt about that. But you have to start to wonder is, do I keep the same rules of engagement in Omaha, Nebraska, that I have in New York City with that type of mindset, both for businesses and let's keep it in your sweet spot, and the surgeons, these ASCs, what's keeping them from getting back to work and helping people who have elective surgeries, yet are hips, knees, shoulders, etc.
Yeah, I mean, if you can mobilize the ventilators, if you can mobilize the PPE to the hotspots, which we should be able to do. I mean, this is our country. We got the greatest country in the world. We should be able to figure this stuff out.
Just give it to Amazon.
Yeah, exactly. And then you move forwards, and then you hold off on certain areas. You make some quarantines. Don't let people travel, but you can still get the economy moving, and it's coming. I can tell you, people are starting to get a sense. The first 2-3 weeks, it was like, okay, we get this. But it's funny. I talked to some other friends, and they're paralyzed. They're like, we're all gonna get sick. This surge is coming. It's going to leave New York. It's coming all across the country, and the whole world's going to be sick, and we're all going to die of COVID. Where it may be 60% of patients are already positive, had no symptoms, and have already moved on. So let's talk about a hall pass, right? Can we get an antibody test? Can we start testing people, primary people, and get them out of the house and start moving around to do stuff? Another, we're worried about testing. Let's really get that antibody test out. I think that would make a huge difference.
Yeah, and then you start the triage coming back. Maybe we are wearing masks as we return back to 6 feet apart, and not bro hugging out, and then just re-engaging slowly and get things going. Because I think it's as much of a spiritual sort of journey that people need to get going, on top of the economic and certainly professional side.
Yeah, people have lost their purpose and their empowerment. They're sitting at home. Some people are getting it and seeing through the smoke and trying to come up with solutions. I mean, one of my favorite sayings is, when there's obstacles, there's opportunities. And so I'm the chief medical officer of OrthoLazer Orthopedic Laser Centers, which is a new franchise that we've established. It's an alternative pain source for acute and chronic orthopedic pain. It's non-operative, can't feel it, can't see it, and we were doing well. We were opening up at about a center a month, so we were up to about 5 centers, and then COVID hits, and then everything obviously gets shut down. Now, some people would look at that and say, "Well, all right, that's a problem. Your business is shut down. You're not going to be able to go to work. What are you going to do?" I looked at it and said, "This is an opportunity. There are going to be surgical queues. The elderly are going to, get in long lines for their joint replacement. They're going to be in pain. They're going to need another treatment option. The younger patients who have jobs have been out of work for 2 months. They need to go to back work yesterday. They're not going to go have rotator cuff surgery and be out for 3 months. They're going to need pain relief as well." So we're seeking out, innovative entrepreneurial orthopedic surgeons that can see through the smoke and say there are solutions out there, while others are sitting at home saying, I'm not leaving the house.
Yeah. Yeah. And again, there's three buckets. I always say there's the bucket where somebody goes fetal, and then there's the bucket where somebody gets that 1,000-yard stare, right? And then you got the people who see the opportunity. And this is typically what happens in these moments is people pivot and create brand new categories of business. Telehealth, right? Massachusetts, I think, was the very first to make it reimbursable 2 weeks ago on the telehealth side. And now that will be the norm moving forward.
Yeah, the way in which we deliver medical care after this pandemic is going to be different. It just is. I mean, we're on with Mike Greiwe, who's the CEO of OrthoLive, and he has this HIPAA compliant platform for telemedicine, and his business grew by like 20% in a week. He couldn't, the phones were ringing off the hook. We have a physical therapist that we spoke to that has a online platform that improves patient care as well. That's a digital platform. So it's just going to be different. Telemedicine is going to be a part of how we do things. You're right about distancing. We're going to think differently about the viruses and how they affect us. But I think that we need to have solutions. We need to be thinking about this. It's incredibly sad about the loss of life and the devastation to our families and friends. But we're not going to be in this forever. And what's our plan to get out?
Yeah. I don't want to let it go by because in the beginning you were the opioid sparing surgeon, and the fro thing's cool too. I want to get to that. But on the opioid side, let's talk about that. We've heard a lot about that, certainly. And typically, I'm in Delray Beach, which really was the rehab capital of the U.S. for a couple of years. And that's driven by the opioid crisis. Cover that with me on how are you the opioid sparing surgeon?
Yeah, so we all got schnookered. The entire society of doctors, nurses, even our major societies. We somehow, some way, there was this messaging that was coming through that opioids were not very addictive. They were inexpensive to use. You could provide pain relief, and we had an obligation to our patients to provide them pain. So they came up with this scale, the pain scale, and then the faces, and all these other things. And at the end of the day, if you didn't get your patients to check off on a national survey from the federal government that their pain was well controlled, then you'd actually be reduced in your reimbursement to the hospital as well as to the surgeon. So there was this huge push across all aspects of care. And then pain became a vital sign, which is ridiculous, right? How is that an objective measurement, right? Some people have zero pain, other people it's 10 out of 10, and they're 10 out of 10 and they're holding their cell phone and talking. So you can't judge it that way. So we sort of moved away from there. And the bottom line is we started seeking out alternatives for opioids. And there's some great solutions that were available. I started about 7 or 8 years ago. There's a company called Pacira, a pharmaceutical that developed a medication called Exparel, which is liposomal bupivacaine. It's a long-acting form of an anesthetic. So anesthetics work, they're great, they numb you, but they didn't last very long. This one lasts for 24 to 72 hours. So I call it the storm of pain. So in the first 72 hours after your surgery, it hurts like hell, right? But after 3 days, it's not like the knife was still on your skin, it feels better. So we give you a soft landing through that time period. And then we've developed these multimodal pain management solutions. So the bottom line is that in some of the most painful orthopedic conditions at this point, we're doing them in ASCs as outpatients, and most of our patients are near opioid free. I'll give you three numbers because I always like to quote these numbers. It's super crazy how addictive they are: 6, 13, and 30. So as a physician, if I write a 24-hour prescription of opioids, 6 out of 100 people will still be on opioids at 1 year. If I do a 10-day supply, 13 out of 100 are still on medication. And if you do a month supply because you've had major back surgery, 30% of people are still on opioids at 1 year.
Where do I get them? Where do I get them? Because they're now such a controlled substance then. Where's that lead?
So we're not giving them because you don't need them.
I know you're not giving them, but you're not talking to a rational person who's addicted. So where do they go?
Okay, so the patients that are already on medication, they basically have been centered around pain management specialists. Primary care doctors were also involved as well. The problem is the pendulum has swung completely away. So now it's the other side. So doctors are like, I'm not going to give you opioids, and they cut you off in the midst. And that's not easy. And most people have a really hard time with that. And so we're trying to figure out a way to find the balance. The one thing that I can do, my superhero powers with opioids, are to prevent the next wave of patients of ever getting addicted. I want you to be opioid naive throughout your entire surgical procedure. So we operate, you don't take any opioids, you get through the worst of it, and you're back to work faster. The patients that are already on the opioids, that's another issue and still need to be dealt with.
Okay, so let's go to today. We're in a COVID scenario. I'm a patient of yours. I can't come see you. How does telehealth potentially bridge that today, or let's call it 2 months from now? How does medical practice change relative to that?
Great question. So I don't think that telehealth is going to replace the physician-patient relationship entirely. I think that as a physician, if I'm going to be operating on you, you're going to want to see me. I think that face-to-face interaction, the personal touch, examination, of being able to have that interaction is really important. And it's something that I cherish. And that's why I love being a doctor. It's caring for my patients and making them better. But what I do see is that, I'm just north of Boston and I do some cool procedures. People come and travel from a distance. Hey dude, let's do your post-op visit over the telehealth. Why do you have to come in? We'll do that right online. It's super easy. You can show me your range of motion and movement. I can look at the wounds right in here. You can tell me how you're doing. And then I can forward a prescription right over to physical therapy, and we'll see you in 4 weeks if we need to see you. If in this situation right now, let's talk about current pandemic situation. So it's a really good way to interact with a patient you've never met before to at least start a conversation. So let's say it's an elderly patient who's 70 years old that's got osteoarthritis knee pain. So for that patient, I'm going to talk. We can figure it out. Okay, you're in severe pain. You're not walking very well. I'm going to bring you into the office. We're going to minimize your exposure to staff as well as to patients. And we'll do an intra-articular injection of cortisone. I'm going to do a longer acting cortisone. We have this new medication called Zilretta, which I love, which is a predictable outcome of up to 3 months of pain relief. So they can actually come in, get treated, and head on out. And then in the post-pandemic world, as I said, I think it's great for post-op visits. I think for routine evaluations. And then, look, I like to consider myself to be kind of a big deal. And if somebody wants to come and see me from Detroit for an initial consultation, hey, man, I know Sharif Bichet is my dear friend. He'll take good care of you. But if you want a second opinion, we can do it online. And that was an advantage for many orthopedic surgeons. there were only 40 states that had parity laws prior to the 1135 Medicare waiver that just came through. Now all 50 states will have parities, which is great. So you can, not have to travel to still see your doctor. And I think post pandemic, we're hoping that those parity laws will stay so that you can see people all around. But what's even better now is that, as physicians, you can actually get paid for your time to see the patient.
And they
so
don't
that's
have, and they don't have to come into your office.
And they don't have to come to the lab, and you're keeping the lights on for a lot of these places. Remember, I mean, we're not big business. We don't have large, cash flow. We don't have a lot of money in the bank. When the revenue dries up, our bank accounts go down. That's it. So we're probably not taking salaries next month as, as the clinicians. So it's trying times.
Yeah, it's an interesting time for sure. Is there anything I didn't cover with you on this that we should talk about in regards to the other side? Telehealth, digital health, practice leadership, practice management?
Yeah, no, I think we did good. I mean, I think that the message that it's going to be interesting. I think the next 2 weeks are really going to be crucial as we really look at the numbers, because the governments and the hospitals have really been doubling down on these surge dates. And so, if it turns out that 2 weeks from now we're still at 40 patients in my hospital, are we going to then start allowing some movement? Now, I think Easter's a little too soon. He was probably off by a couple of weeks, but I think by May 1st, you're going to probably start hearing some outcries that people are going to want to start going back to work and getting our economy moving.
Yeah, but we're going to need a diagnostic. I don't think you can just blindly say, okay, everybody's good, let's assume nobody's got it. I think we need an antibody test, and I think that you need to wear, listen, you're going to have a scarlet letter. You're going to, or not have one. Everybody's going to have a wristband on saying, I've been tested or I have the antibodies. That's going to be a very interesting social situation.
No, agreed. I think it's so funny. I think my wife, I'm convinced, had it. And we're probably running short on time, but we were in Paris in 3 weeks in February, and she came back and she had this pneumonia and she just couldn't breathe. And she had 2 rounds of antibiotics. So this was before anybody even had testing for it. And her PCP got back to me, like 2 weeks later or 3 weeks later, she's like, I think she probably had it. And so then I think I probably had it, but I didn't have any symptoms. So I'm like, let's get that antibody test out and rolling and see if we can't get people moving.
Yeah, and use it for plasma donation in order to kickstart.
100%. Yeah. For treatment, for sure.
Yeah, for treatment. Yeah. Well, Scott, this has been awesome. I appreciate it. Appreciate you taking the time out of your busy schedule from Boston and joining us here.
Yeah, it's a pleasure. Thank you so much for having me.
You bet. Be well. And this has been Joe Mullings with The Other Side.